This is concept 13 in concepts, intracranial regulation. Goals for this concept presentation: define and describe this concept. Notice risk factors that place individuals at risk for intracranial regulation problems. Recognize when an individual has signs of impaired intracranial regulation. Provide appropriate nursing and collaborative interventions for optimizing intracranial regulation. The brain is a highly complex organ that processes internal and external stimuli and controls body functions. As the largest component of the central nervous system, the brain lies within the cranium and is protected by the skull. The intracranial regulation, ICR, concept includes normal and abnormal processes of intracranial function. Nurses care for individuals experiencing a wide variety of ICR issues in both community and inpatient settings. Definition: the term cranium refers to the collective bone structure that encloses the brain, also known as the skull. The prefix intra refers to within. Thus, the term intracranial refers to those components that lie within the skull, which include the brain, circulatory system, and dura mater. Regulation is a term that refers to compliance and maintenance of balance. In the case of intracranial regulation, it is referring to maintaining a balance to promote an environment that is conducive to optimal brain functioning. The concept of ICR includes anything that affects the contents of the cranium and impacts the regulation of maintaining an optimally functioning brain. For the purpose of this concept presentation, ICR is defined as mechanisms or conditions that impact intracranial processing and function. Although the brain receives input from outside the cranium, specifically through the peripheral nervous system and the spinal cord component of the central nervous system, this concept does not include problems with the peripheral nervous system or the spinal cord. ICR focuses on those conditions that specifically affect the contents of the cranium. As will be discussed further, there are many variables that can upset this balance with potentially devastating results. The scope. The scope of this concept ranges from normal to impaired function. See Figure 13.1. When functioning optimally, ICR allows individuals to function normally. Impairment can be caused by a number of factors, including reduced blood flow to the brain, compromised neurotransmission, and damage to brain tissue. The resulting neurologic dysfunction can range from minimal to severe. Normal physiologic processes. The brain is the primary structure associated with intracranial regulation and is part of the central nervous system, serving as the primary control center for the body. Anatomically, the brain is divided into the following areas: the cerebrum, the diencephalon, the cerebellum, and the brainstem. See Figure 13.2. Normal intracranial regulation involves interaction among these structures through a complex communication system. Table 13.1 presents general functions of these structures for reference. Neurons are cells within the nervous system designed for the transmission of information within the brain and throughout the body. Neurons direct signals from cell to cell through dendrites and axons. Optimal ICR is dependent on the transmission of nerve impulses across neuronal synapses by neurotransmitters. Brain function depends on a consistent supply of blood delivering oxygen and nutrients. A sufficient volume of blood and cardiac function is required for adequate perfusion. The level of oxygen in the blood is dependent on gas exchange in the lungs and hemoglobin capacity. Likewise, because carbohydrates are the main source of fuel for the brain, optimal ICR is dependent on blood glucose levels. Several other unique physiological processes are in place to protect and preserve critical brain functions, and these are described next. Cranial vault or skull. The skull is composed of multiple bones that act as a rigid, non-compliant protective covering of the brain. Within the skull are three components: brain tissue making up 80%, blood making up 10%, and cerebrospinal fluid making another 10%. Intracranial pressure, ICP, is the sum of the pressure exerted by these three volumes in the skull. In adults, ICP is normally less than or equal to 15 milligrams mercury. A sustained ICP of greater than or equal to 20 millimeters mercury is considered intracranial hypertension. Because the total volume inside the skull cannot change, A change in one compartment necessitates a change in another. This interrelationship of volume and compliance of the three cranial components is known as the Monroe-Kelly doctrine. Blood-brain barrier. Between the arterial and venous network of the brain is a unique capillary system called the blood-brain barrier, BBB, which consists of a tight layer of endothelial cells. This restrictive barrier makes it difficult for neurotoxic substances to pass into the brain. This barrier may become compromised secondary to decreased perfusion. Categories of impaired intracranial regulation. There are several categories that describe impairment of dysfunction associated with ICR. These include problems associated with perfusion, neurotransmission, glucose regulation, and pathologic processes. These categories are briefly described next, and the pathologic consequences of these impairments are detailed in the sections that follow. All these impairments can occur across the lifespan, although some are more prevalent in particular age groups. Impaired perfusion. First, for the brain to function optimally, there must be a consistent supply of blood delivering oxygen and nutrients. Impairment in blood flow, reducing oxygenation of the blood, or reduced blood glucose can lead to a significant dysfunction. Intracerebral perfusion can be disrupted in a number of different conditions, such as internal blockage of a vessel, severe hypotension, or loss of a vessel integrity attributable to damage or excessive external pressure on a vessel that exceeds perfusion pressure. For example, an ischemic stroke is the result of inadequate perfusion past the thrombus or embolus. Perfusion can also be disrupted as the result of an intracranial hemorrhage, such as a subdural hematoma or a subarachnoid hemorrhage caused by a traumatic brain injury. A disruption of cerebral perfusion leads to a wide variety of ICR problems depending on the area of the brain that is affected and the length of time before perfusion is restored. Compromised neurotransmission. Optimal functioning of the brain is dependent on the transmission of nerve impulses across neuron synapses by neurotransmitters. Normal transmission requires fully functioning neurons, nerves, and neurotransmitters. Presynaptic neurons release neurotransmitters that travel to postsynaptic neurons. Neurotransmitters can be either excitatory or inhibitory. Many components of this process can be disrupted. Degenerative diseases disrupt brain functioning by the loss of neurons, which also disrupts neurotransmission. The concentration of the neurotransmitter acetylcholine glucose regulation. Because the brain can't store glucose, a constant supply is needed to maintain optimal functioning. Areas of the brain that are particularly sensitive to hypoglycemia are the cerebral cortex, hippocampus, and cerebellum. Prolonged hypoglycemia may cause widespread neuronal injury. Children who have smaller glycogen stores are particularly susceptible to hypoglycemia, which can adversely affect brain tissue. Hyperglycemia is a glucose level greater than 126 milligrams per deciliter can also cause problems by augmenting brain injury in acute stroke. Some of the deleterious effects of hyperglycemia are worsened ischemic damage, an increased infarction size, an increased blood-brain barrier permeability. The optimal glucose range is being studied but is yet to be determined. Pathology. There are many pathologic states that disrupt intracranial functioning and regulation. Pathology of the brain can take many forms, such as brain tumors, degenerative diseases, and inflammatory conditions. Many degenerative diseases of the brain are clinical exemplars of the ICR concept. Alzheimer's disease is a degenerative process that results in the loss of neurons, primarily in the gray matter of the brain. Parkinson's disease as a result of damage to the basal ganglia, and Huntington's disease is a degeneration of striatal neurons. Although the degenerative process varies with each of these diseases, the result is the same: disruption of brain regulation and function. The most common inflammatory conditions of the brain are abscesses, meningitis, and encephalitis. Although the etiology varies, or the cause for each condition, the result is an inflammatory response that can result in disrupted cerebral function and regulation. Physiological consequences and processes. Regardless of the specific condition or cause, when there is impaired blood flow, compromised neurotransmission, and damage to brain tissue from trauma or other pathologic conditions, Significant pathophysiological consequences can occur. Review of central nervous system anatomy and physiology. Cranial vault or skull. The skull is composed of multiple bones that act as a rigid, non-compliant protective covering of the brain. Within the skull are three components: brain tissue 80%, blood 10%, and cerebrospinal fluid 10%. Intracranial pressure, ICP, is the sum of the pressure exerted by these three volumes in the skull. In adults, ICP is normally less than or equal to 15 millimeters mercury. A sustained ICP of greater or equal to 20 millimeters mercury is considered intracranial hypertension. Because the total volume inside the skull cannot change, a change in one compartment necessitates a change in another. These interrelationships of volume and compliance of the three cranial components is known as the Monroe-Kelly doctrine. Blood-brain barrier. Between the arterial and venous network of the brain is a unique capillary system called the blood-brain barrier, which consists of a tight layer of endothelial cells. This restrictive barrier makes it difficult for neurotoxic substances to pass into the brain. This barrier may become compromised secondary to decreased perfusion. Meninges. These are three layers of protective membranes that surround the brain and spinal cord: the dura mater, the arachnoid layer, and the pia mater. The area between the arachnoid layer and the pia mater is referred to as the subarachnoid space, which contains cerebrospinal fluid. ICR problems are frequently referred to in relation to the meningeal layer location. For example, subarachnoid hemorrhage, subdural hematoma, or epidural hematoma. Meningitis is an inflammatory condition of the meninges. Autoregulation. Cerebral blood flow is normally maintained at a relatively constant rate by intrinsic cerebral mechanisms referred to as autoregulation. Autoregulation adjusts regional CBF, cerebral blood flow, in response to the brain's metabolic demands by changing the diameter of cerebral blood vessels. Cerebral arterial walls are thinner than those in the systemic circulation because of a lack of smooth muscle and a decreased thickness of the tunica media. They also do not have the ability to develop collateral circulation in response to ischemia. Autoregulation allows the cerebral circulation to deliver a constant supply of blood despite wide fluctuations in systemic blood pressure. Cerebrospinal fluid. CSF is produced at a rate of approximately 20 milliliters per hour, circulates within the subarachnoid space, and then is absorbed into the venous system. It acts to cushion and support the brain and other structures of the CNS and provides nutrients. CSF analysis provides useful diagnostic information related to certain nervous system conditions. Hyperventilation. Another protective mechanism in response to increasing cerebral volume is spontaneous hyperventilation. Carbon dioxide is a potent vasodilator. Hyperventilation is a compensatory mechanism that causes vasoconstriction, which reduces cerebral blood volume and ICP, intracranial pressure. Consequences. Regardless of the specific condition or cause, when there is impaired blood flow, compromised neurotransmission, and damage to brain tissue from trauma or other pathologic conditions, significant pathophysiological consequences can occur. Cerebral edema. Cerebral or brain parenchymal edema occurs for many reasons. Box 13.1 shows common causes of cerebral edema. Mass lesions, such as a brain abscess, brain tumor, primary or metastatic, hematoma, intracerebral, subdural or epidural, hemorrhage, intracerebral, cerebellar or brainstem, head injuries and brain surgery, contusions, hemorrhage, post-traumatic brain swelling, cerebral infection, meningitis, encephalitis, vascular insult, anoxic and ischemic episodes, hemorrhagic stroke, ischemic stroke, thrombotic or embolic, and venous sinus thrombosis, toxic or metabolic encephalopathy conditions, lead or arsenic intoxication, hepatic encephalopathy, and uremia. Cerebral edema is a symptom that is common to many ICR conditions. Cerebral edema may be classified as vasogenic, cytotoxic, or interstitial. Regardless of the classification or origin of cerebral edema, the result is an increase in brain size that will negatively affect perfusion and oxygenation to the brain. As discussed next, signs and symptoms will become evident to varying degrees based on the location and amount of cerebral edema. Increased intracranial pressure. Elevated ICP is a potentially devastating complication of neurologic injury caused by many different conditions. Pathologic ICP is evident at sustained pressures greater than or equal to 20 millimeters mercury. Several conditions may cause increased ICP, such as TBI, traumatic brain injury, ruptured aneurysm, central nervous system infections, hydrocephalus, and brain tumors. Symptoms of increased ICP include headache, decreased level of consciousness, and vomiting. Signs may include cranial nerve 6 palsies, papilledema, and periorbital bruising. A late sign is Cushing's triad. See increased intracranial pressure later in this concept. The untoward consequence of increased ICP is impaired perfusion. Brain tumors. A tumor can occur in any part of the brain and spinal cord. Brain tumors are most commonly a result of metastasis from another primary site outside the brain. Clinical manifestations will depend on the size and location of the tumor. Risk factors. Populations at risk. All populations are potentially at risk for problems with ICR because there are such a wide variety of conditions included in this concept. Depending on the condition, some populations are at a higher risk. ICR problems related to degenerative pathology have a higher incidence in the elderly population. Injury-related ICR problems are more commonly seen in the adolescent and young adult age groups. The leading cause of traumatic brain injury are falls and motor vehicle accidents. Falls are more of an issue with the very young and elderly. Because of risk-taking behavior, motor vehicle accidents are more prevalent in the young adult population. Individual risk factors. Individual risk factors are dependent on the cause of injury or pathology. For example, the risk factors for stroke include age, hypertension, diabetes, smoking, obesity, and cardiovascular disease. Some of the degenerative pathologic conditions have a strong genetic component and put certain individuals at higher risk. Page 116, age-related differences. The brain undergoes significant development during infancy and childhood. At birth, brain function is primarily limited to primitive reflexes and is sufficiently developed to sustain extrauterine life. Extensive development occurs thereafter during the first few years, not only in size but also in function. Throughout childhood, a child's growth and development is influenced by evolving cognitive, emotional, and motor functions within the brain. Cranial sutures are ossified by age 12 years with no expansion of the skull after age 5. Before the sutures are entirely closed, there is some room for expansion in the case of cerebral edema and increasing ICP. Aging is associated with a reduction in brain size, weight, and number of neurons. Atrophy of neuronal dendrites causes a slowing of neurotransmission and neural processes. These changes, however, are not directly associated with mental function, and cognitive abilities remain intact in the absence of disease, although cognitive function is enhanced with continued stimulation. Variations in context. There are several categories that describe impairment or dysfunction associated with intracranial regulation. These include problems associated with perfusion, neurotransmission, glucose regulation, and pathologic processes. These categories are briefly described next, and the pathologic consequences of these impairments are detailed in the sections that follow. All of these impairments can occur across the lifespan, although some are more prevalent in particular age groups. Impaired perfusion. For the brain to function optimally, there must be a consistent supply of blood delivering oxygen and nutrients. Impairment in blood flow, reduced oxygenation of the blood, or reduced blood glucose can lead to significant dysfunction. Intracerebral perfusion can be disrupted in a number of different conditions, such as internal blockage of a vessel, severe low blood pressure, or loss of vessel integrity attributable to damage or excessive external pressure on a vessel that exceeds perfusion pressure. For example, an ischemic stroke is the result of inadequate perfusion past the thrombus or embolus. Perfusion can also be disrupted as a result of an intracranial hemorrhage, such as a subdural hematoma or subarachnoid hemorrhage, caused by a traumatic brain injury. A disruption of cerebral perfusion leads to a wide variety of ICR problems, depending on the area of the brain that is affected and the length of time before perfusion is restored. Compromised neurotransmission. Optimal functioning of the brain is dependent on the transmission of nerve impulses across neuronal synapses by neurotransmitters. Normal transmission requires fully functioning neurons, nerves, and neurotransmitters. Presynaptic neurons release neurotransmitters that travel to postsynaptic neurons. Neurotransmitters can be either excitatory or inhibitory. Many components of this process can be disrupted. Degenerative diseases disrupt brain functioning by the loss of neurons, which also disrupts neurotransmission. The concentration of the neurotransmitter acetylcholine is reduced in Alzheimer's disease secondary to the destruction of acetylcholine secreting neurons. Neurotransmitters can be affected by drugs and toxins, which can modify their function or block their attachment to receptor sites on the postsynaptic membrane. For example, heroin binds to presynaptic endorphin receptors and reduces pain by blocking the release of the neurotransmitter that causes pain. Seizures are aberrant neuronal activity that can manifest clinically as disrupted motor control, sensory perception, behavior, and/or autonomic function. Glucose regulation. Because the brain cannot store glucose, a constant supply is needed to maintain optimal functioning. Areas of the brain that are particularly sensitive to hypoglycemia are the cerebral cortex, the hippocampus, and the cerebellum. Prolonged hypoglycemia may cause widespread neuronal injury. Children who have smaller glycogen stores are particularly susceptible to hypoglycemia, which can adversely affect brain tissue. Hyperglycemia, glucose level than 126 milligrams per deciliter, can also cause problems by augmenting brain injury in acute stroke. Some of the worst effects of hyperglycemia are worsened ischemic damage, an increased infarction size, and increased permeability into the blood-brain barrier. The optimal glucose range is being studied but is yet to be determined. Pathology. There are many pathologic states that disrupt intracranial functioning and regulation. Pathology of the brain can take many forms, such as brain tumors, degenerative diseases, and inflammatory conditions. Many degenerative diseases of the brain are clinical exemplars of the ICR concept. Alzheimer's disease is a degenerative process that results in the loss of neurons, primarily in the gray matter of the brain. Parkinson's disease is a result of damage to the basal ganglia, and Huntington's disease is a degeneration of striatal neurons. Although the degenerative process varies with each of these diseases, the result is the same: disruption of brain regulation and function. The most common inflammatory conditions of the brain are abscesses, meningitis, and encephalitis. Although the etiology varies with each condition, the result is an inflammatory response that can disrupt cerebral function and regulation. Assessment. History. A thorough history should be solicited from the patient or family member if the patient is unable to provide information. Patient presentation will help direct the practitioner to the most relevant areas of inquiry. Information in a history that provides data about intracranial function can relate to multiple systems. Asking pertinent questions will provide clues to the examiner of ICR problems and will help to focus the physical exam. Potential ICR areas on which to focus include the following: numbness, paralysis, tingling, neuralgia, loss of consciousness, dizziness, fainting, confusion, changes in recent or remote memory, changes in vision, hearing, balance, or gait, speech problems, expressive and/or receptive, chewing and swallowing problems, muscle weakness or loss of bowel or urinary control, onset of unexplained tremors or other motion disturbances, unexplained severe headaches, vomiting, yet the symptom onset, history of head injury. Examination findings. Objective examination findings that convey neurological status are found throughout a physical exam. Specific signs of dysfunction vary according to the ICR problem. Many age-related degenerative changes occur in the CNS. When assessing an older adult, it is important to distinguish between the expected changes and changes potentially related to an ICR problem that could improve with appropriate treatment. Findings common to most conditions are a change in mental status and motor function. Some of the more common examination techniques and tools are discussed next, but these are not all inclusive. Mental status. A complete mental status examination includes assessment of the individual's emotional responses, mood, cognitive functioning, and personality. Depending on the patient's presenting condition, the nurse will decide which components of the exam are relevant. If it is not practical or necessary to do a complete mental status exam, the mini mental status examination is an option, which is a simplified scored form of the cognitive portion of the mental status examination. It consists of 11 questions and takes only 5 to 10 minutes to give. Cognitive functioning should be intact in the healthy elderly client, although some changes may occur as individuals grow older. When assessing an elderly patient, it is essential to determine the patient's baseline neurologic functioning in order to establish if there are significant changes. Glasgow Coma Scale. Glasgow Coma Scale, known as the GCS, is used to give a standardized numeric score of the neurologic patient assessment. This is a widely used measurement tool that consists of 3 components: eye-opening, verbal response, and motor response. Although this is an objective measurement tool, there is room for subjective interpretation of assessment findings. To minimize subjectivity and facilitate consistency, when transferring care of a patient, nurses should complete the GCS together and agree on the values. Changes in the GCS will help to determine treatment methods and priorities. Table 13.2 describes the components of the GCS. This is on page 119. Intracranial pressure. The earliest sign of increased intracranial pressure is a change in the level of consciousness. Another early sign is headache. Headache characteristics associated with increased ICP include nocturnal awakening, pain worsened by cough or defecation, recurrent and localized, and progressive increase in frequency or severity. Vomiting, usually not preceded by nausea, is often a nonspecific sign of increased ICP. Infants have less specific symptoms of increased ICP, such as irritability, bulging fontanelles, lethargy, flat affect, and poor feeding. Retinal hemorrhage in children with increased ICP should raise suspicion of non-accidental head trauma. Infants with elevated ICP may develop macrocephaly, split sutures, or a bulging fontanelle. ICP is measured using a catheter placed in one of the following locations in the cranium: intraventricular, intraparienychimal, subarachnoid, or epidural. The most common placement is in the lateral ventricle. Patients must be in an intensive care environment for this type of monitoring. Most commonly, ICP monitoring is done in trauma patients with a closed head injury. Some other indications include stroke, intracerebral hemorrhage, hydrocephalus, and subarachnoid hemorrhage. Guidelines for management of severe head injury recommend that ICP monitoring is indicated in comatose head injury patients with a GCS score of 3 to 8 and with an abnormal computerized tomography scan. The goal of care is to keep the ICP less than 20 millimeters mercury. Catheters are available that monitor ICP, drain cerebrospinal fluid, and measure brain oxygenation. When the patient has increased ICP, the catheter may be used for therapeutic drainage of CSF in order to reduce ICP. If hydrocephalus is present, a ventriculostomy may be used to remove CSF. In children, a sunsetting appearance of the eyes is evident with increased ICP. In some instances, a permanent catheter is placed to drain CSF, which is known as ventriculoperitoneal shunt. Cushing's triad is useful in explaining the late signs of increased ICP. It is a serious late sign of increased ICP and an indication of impending herniation. The triad consists of hypertension with widened pulse pressure, bradycardia, and changes in respiratory pattern in the presence of increased ICP. Pupil and vision changes may become apparent as edema impinges on cranial nerves 2, 3, 4, and/or 6. National Institutes of Health Stroke Scale. The National Institutes of Health Stroke Scale is an example of one type of specific tool for nurses to use when assessing a patient following a stroke. This scale, composed of 11 items, has been widely used and validated. The score on admission has been correlated to stroke outcome and is recommended for all patients with suspected stroke. Diagnostic test. When an ICR problem is suspected, time is of the essence. Diagnostic tests that can quickly give the most pertinent information are recommended initially. Neuroimaging studies. Imaging studies are essential to obtain in patients presenting with sudden neurologic deterioration, and they may be utilized with non-emergent conditions such as suspected brain tumor. A non-contrast CT or MRI scan should be performed as soon as possible to determine the origin of the neurologic injury. Current guidelines recommend a head CT for all traumatic brain injury patients with a GCS of 14 or lower, which can detect skull fractures, intracranial bleeding, and cerebral edema. Advanced CT and MRI technologies such as magnetic resonance angiography and positron emission tomography are available that can distinguish between brain tissue that is irreversibly infarcted and that which is potentially salvageable, which will help when deciding appropriate treatment. Skull radiograph. Depending on the mechanism of action and patient presentation, a skull X-ray may be ordered to detect fractures, bone erosion, calcification, and/or abnormal vasculature. Electroencephalogram. An electroencephalogram measures and records the brain's electrical activity through multiple electrodes placed on the scalp. Video EEG monitoring refers to continuous EEG monitoring over a prolonged period of time while simultaneously recording the patient's movements and activity. This monitoring combination is useful in diagnosing and localizing the area of seizure origin. The EEG is also helpful in identifying psychogenic, non-epileptic seizures. The origin of these seizures may be associated with psychological conditions or other physical problems, but they are not caused by electrical activity in the brain. Brain biopsy. To determine the type and stage of a brain tumor, a biopsy is performed, usually during a surgical procedure. Preliminary histologic type can be usually determined quickly in the operating room, then the tumor is sent to pathology for complete analysis and final determination. Lumbar puncture. The lumbar puncture or spinal tap may be indicated when infection is suspected. A lumbar puncture should be deferred until after the head CT scan if intracranial hypertension is suspected, because brain herniation may be precipitated by increasing the pressure gradient between the cranial vault and the spinal cord. Primary prevention. Primary prevention strategies are intended to maintain optimal health and prevent injury or disease. This applies to intracranial regulation in many ways. Leading a healthy lifestyle, which includes smoking cessation, maintaining a healthy weight, controlling blood pressure, and exercising, can decrease the risk of vascular disease impacting the cerebral arteries. This is linked to risk reduction for stroke. Injury prevention measures such as proper use of seatbelts and/or helmets, knowledge of firearm safety, and participation in violence prevention programs reduce the risk of traumatic brain injury. Healthy People 2020 has identified the following 3 objectives specifically related to the prevention and reduction of brain injury. Reduce fatal traumatic brain injuries, reduce hospitalization for non-fatal traumatic brain injuries, reduce emergency department visits for non-fatal traumatic brain injuries. Secondary prevention. There are no true screening tests available related to ICR. In the event of injury or the presence of clinical findings suggesting intracranial dysfunction, specific diagnostic tests are initiated to determine a cause. Collaborative interventions. There are many interventions related to caring for patients with ICR issues. A few of the most common examples are discussed. The overarching goal of caring for patients is to prevent secondary injury, damage to the vulnerable adjacent tissues, by improving cerebral perfusion. This is primarily achieved by decreasing cerebral edema and ICP, which will improve oxygenation to prevent cell death. Pharmacotherapy. Because impairments in intracranial regulation represent a large number of conditions, there are many classes of pharmacologic agents associated with this concept. Table 13.3 presents these agents, and they are described further here. Osmotic diuretics. Osmotic diuretics create an osmolar gradient that draws water across the blood-brain barrier, leading to a decrease in interstitial volume and a subsequent decrease in ICP. Mannitol is the agent used most commonly to achieve ICP control in a variety of conditions, and has been shown to improve cerebral blood flow. Hypertonic saline is increasingly being used, but research has not clearly determined the volume, tonicity, or most effective method of administration. Sedatives. Sedatives can decrease ICP by reducing metabolic demand. Propofol, otherwise called Diprivan, is frequently used in the intensive care unit setting because it has a short half-life and is easily titrated, permitting frequent neurologic assessment. Barbiturate coma is sometimes used as a final effort in the case of uncontrolled increased ICP, but there is little clinical evidence to support its use. Benzodiazepines such as lorazepam, Ativan are another sedative option. Analgesics. Pain increases oxygen demand. In addition to controlling pain for comfort, it should be controlled to avoid compromising sufficient oxygen delivery to ischemic neuron cells. The use and choice of sedative agents should be individualized according to specific clinical circumstances and provider expertise. Short-acting narcotics such as fentanyl or morphine are generally preferable to allow for periodic neurologic assessments. Anti-epileptics. Seizures can exacerbate or cause increased ICP and increased oxygen demand. Anti-epileptics may be used as a prophylactic or treatment measure. These medications act by stabilizing nerve cell membranes and preventing the distribution of the epileptic discharge. Initial seizure management of traumatic brain injury patients includes phenytoin, or Dilantin, or valproic acid, known as Depakote. Patient education is important because there are many serious side effects associated with anti-epileptic medications. The U.S. Food and Drug Administration issued a warning in 2008 related to the risk of suicidal thoughts and behaviors associated with 11 anti-epileptic medications. Glucocorticoids. Glucocorticoids may be indicated for use in some ICR problems and are contraindicated in others. Dexamethasone, otherwise known as Decadron, may be effective in reducing cerebral edema related to tumors, abscesses, and CNS infections. Glucocorticoids are associated with a poor outcome in treating moderate to severe head injury and should not be used in this patient population. Antipyretics. Fever may worsen the outcome after stroke and severe head injury by aggravating secondary brain injury caused by increased metabolic demand. Normothermia should be maintained through the use of antipyretic medications such as acetaminophen or by implementation of other treatment modalities such as mechanical cooling. Antihypertensive medications. Depending on the ICR condition, antihypertensive medications may be detrimental or beneficial. Mean arterial pressure must be adequate to maintain sufficient CPP to limit secondary injury. Because of this, higher systemic blood pressures are tolerated in patients with ICR conditions that impair CPP. In these patients, antihypertensive medications are not recommended, and medications may be initiated in order to sufficiently raise the systemic pressure, particularly if the ICP is elevated. Several studies have shown that lowering the systemic blood pressure in patients with acute ischemic stroke has been associated with clinical deterioration. Conversely, reducing blood pressure in patients with a hemorrhagic stroke may be beneficial by minimizing further bleeding and continued vascular damage. Anti-Parkinsonian medications. Anti-Parkinsonian medications attempt to restore the balance of dopamine through one of several mechanisms, depending on drug type. The most effective drugs, called dopaminergic drugs, replace dopamine or mimic its action in the brain. Another group of drugs delays the breakdown of dopamine, thus increasing the level in the brain. Levodopa, otherwise known as Sinemet, is the most commonly used anti-Parkinsonian medication. It is converted to dopamine in the CNS, where it serves as a neurotransmitter. To minimize the side effects of dopamine in the periphery, another medication is administered with levodopa. In the U.S., this drug is carbidopa, which prevents the conversion of levodopa to dopamine until it reaches the brain. Dopamine agonists mimic the effect of dopamine by stimulating the same cells as dopamine. Monoamine oxidase B is an enzyme that breaks down levodopa in the brain. MAOB inhibitors prolong the effectiveness of dopamine and also levodopa. Cholinesterase inhibitors. Cholinesterase inhibitors are prescribed to patients with mild to moderate dementia to make acetylcholine more available, improving cortical function. In moderate to severe dementia, an N-methyl D-aspartate, NMDA, receptor antagonist may have a neuroprotective function as well as decrease dementia symptoms. However, it does not slow progression of the disease. Surgical interventions. Many types of cranial surgery are available to address ICR problems. Some examples are craniotomy, craniectomy, and shunt and stereotactic procedures. A decompressive craniectomy removes the rigid confines of the skull, allowing for expansion of the cranial contents and lowering the ICP. Potential complications of this surgery include herniation through the skull defect, spinal fluid leakage, wound infection, and epidural and subdural hematoma. A craniotomy may be performed to remove a lesion or tumor, repair a damaged area, or relieve pressure and/or drain blood secondary to epidural, subdural, or intracerebral hematomas. Frequently, the origin of seizures is either the hippocampus or the amygdala, which is located in the temporal lobe of the brain. If seizures are found to arise from these areas, a temporal lobectomy surgery is performed to resect the identified area. This surgery is becoming more common and has been successful in obtaining seizure control. Stereotactic procedures allow precise location of a specific area of the brain and may be utilized for dissection or to obtain a biopsy. Shunt procedures place an artificial pathway for excessive CSF to be drained from an area of the brain to an extracranial location using a tube or implanted device. Accumulation of CSF may be due to overproduction, obstruction, or problems with normal reabsorption. Placement of a ventriculoperitoneal shunt is a common example of this type of procedure. Ongoing assessment. With prevention of secondary injury being the goal of patient care, it is of utmost importance to recognize changes in the patient's condition early. For this reason, thorough and frequent neurological assessment is critical in the care of a patient with ICR problems. A complete neurologic assessment includes determination of level of consciousness and measurement of GCS score, along with cognitive, motor, sensory, and reflex testing. Vital signs should be monitored consistently on all patients with an ICR problem. The frequency will be dictated by the condition and acuity of the patient. Assessment should be frequent enough to detect significant changes early so that the appropriate interventions can be implemented to prevent patient deterioration. See the discussion of Cushing's triad in the intracranial pressure section. ICP-CPP monitoring. As discussed previously, it is imperative that the brain receive a constant, adequate blood supply to optimize brain functioning. Severely head-injured patients should receive continuous ICP and CPP monitoring. If these values are not optimal, several possible collaborative and nursing interventions are available. Most guidelines recommend that treatment for elevated ICP should be initiated when ICP is greater than 20 millimeters mercury. Interventions to lower ICP. Positioning. The intracranial venous system consists of canals and sinuses, and unlike the peripheral venous system, it lacks valves. Interventions promoting venous outflow from the head decrease cerebral volume and help to lower ICP. Such interventions include head of bed elevation and proper alignment of the head and neck with the body. Head of bed elevation of 30 degrees is usually recommended to decrease ICP. It's also important to keep the head and neck midline to prevent compression of jugular veins and to limit hip flexion. Head of bed elevation potentially could decrease cerebral perfusion by increasing venous return. Therefore, head of bed elevation is recommended as long as the CPP remains at an appropriate level. Activity management. Balance is needed between being efficient and not increasing oxygen demand when providing nursing care. Clustering of many nursing tasks at once will increase oxygen demand and may compromise cerebral perfusion. Distribution of care procedures over a longer time frame is preferable. Activity management. Balance is needed between being efficient and not increasing oxygen demand when providing nursing care. Clustering many nursing tasks at once will increase oxygen demand and may compromise cerebral perfusion. Airway management. Endotracheal suctioning stimulates coughing, but this increases ICP. Patients with increased ICP should undergo endotracheal suctioning only when suctioning is indicated. In addition, these patients may need to be sedated before the procedure. Careful assessment is necessary to maintain an adequate airway and minimize complications of increased ICP. Hyperventilation. Prophylactic hyperventilation, making the PaCO2 less than 25 millimeters mercury, in TBI is not recommended because it decreases perfusion, which will negatively impact oxygen delivery. Hyperventilation is recommended only as a temporary measure to reduce elevated ICP. A 1 millimeter mercury change in PaCO2 is associated with a 3% change in cerebral blood flow. Hyperventilation can also increase extracellular lactate and glutamate levels, which may contribute to secondary brain injury. Bowel management. Constipation increases intra-abdominal pressure and causes straining when defecating, thereby raising ICP. Stool softeners or laxatives may be necessary to minimize these untoward effects on ICP. Nutrition management. Nutrition management is a high priority when caring for patients with ICR conditions. The nurse should advocate for an early dietary consultation in order to ensure prompt and adequate nutrition to facilitate healing. Depending on the ICR impairment and patient condition, enteral or parenteral feeding may be appropriate. Swallowing function should be assessed before initiation of enteral feeding for certain patients, particularly following a stroke. Patient education. Patient education is always a primary nursing function, which is no exception when caring for patients with ICR. Education should be focused on all levels of health promotion. Problems involving the brain can have devastating and long-lasting effects. Nurses are uniquely qualified and available to assist patients and their families throughout the course of their care. Rehabilitation. Particularly after a stroke or head injury, rehabilitation is an important part of patient care. The focus on returning the patient to optimal functioning. The composition of the rehabilitation team will depend on the patient's needs, which may include speech therapy, physical therapy, and occupational therapy, along with medical and nursing care as needed. As soon as the patient is stabilized in the acute care setting, rehabilitation should begin. It may take months to years to determine how much function will be regained. Interrelated concepts. Many concepts are closely related to ICR. Those considered most important are shown in Figure 13.4 on page 122. Cognition is dependent on an optimally functioning brain. If ICR is disrupted, depending on the area of the brain affected, cognitive function may be impaired either temporarily or permanently. The degree of cognitive function impairment is dependent on the number of neuron cells affected. The brain controls movement, coordination, and balance. Thus, optimal mobility is dependent on an intact neurologic system and effective intracranial regulation. Individuals who have intracranial regulation problems may become immobile as a result of unsteadiness, imbalance, or the inability to initiate or execute purposeful movements to the arms, legs, or trunk. Perfusion and gas exchange are intimately involved with ICR and have been discussed thoroughly in the normal physiological process and physiological consequences section. Without adequate perfusion of oxygen and nutrient-rich blood, the neurons are unable to function. Hormonal regulation is dependent on normal intracranial regulation because of the location of the hypothalamus and pituitary glands within the brain. Damage to these structures or surrounding brain tissue from trauma or disease can have disastrous effects on hormone regulation. Question: what is the earliest sign of increased ICP? Is it nausea, change in level of consciousness, dyspnea, or inability to walk without assistance? The answer is headache and possibly not being able to walk. Question 2. Which surgical procedure may be performed to remove a lesion or tumor to repair a damaged area or to relieve pressure and or drain blood? Is it decompressive craniectomy, stereotactic procedure, shunt procedure, or craniotomy? And your answer should be 4. A craniotomy may be performed to remove a lesion or tumor, to repair a damaged area, or to relieve pressure and or drain blood secondary to epidural, subdural, or CSF problems. Question. A lumbar puncture would be contraindicated if what condition exists? Congenital scoliosis, spinal neoplasm, intracranial hypertension, or Parkinsonian-like symptoms? Your answer should be lumbar puncture should be deferred until after the head CT scan if intracranial hypertension is suspected, because herniation may be precipitated. In addition to this slide, clinical exemplars. There are many clinical exemplars of intracranial regulation. Common exemplars are presented in box 13.2 on page 123. Although exemplars are listed under a specific category, there are instances in which an exemplar could fit under more than one category. For example, brain tumors can be considered pathology and can also cause problems with neurotransmission. Similarly, if a brain tumor is large enough and exerts enough pressure, it can also disrupt perfusion. The categories are not meant to be all-inclusive or exclusive, but rather a suggested organizational framework for ICR conditions. A brief discussion of common clinical exemplars follows. For detailed explanations on the nursing care for all the exemplars, see MedSurg, Pediatric, and Gerontology textbooks. Featured exemplars. Stroke. A stroke occurs when there is a loss of blood flow to an area of the brain, causing the neurons to die. Two major classifications of stroke are ischemic stroke and hemorrhagic stroke. Ischemic stroke is the most common. Stroke is the third leading cause of death and serious long-term disability. Nearly 3/4 of all strokes occur in people older than 65 years. The risk of having a stroke more than doubles each decade over 55 years. In the U.S., stroke death rates are higher for blacks than for whites, even at younger ages. See case study. Traumatic brain injury. TBI occurs when a blow to the head causes injury to the brain. The most common causes are motor vehicle accidents, falls, and violence. Brain injury can range from mild to severe. With significant injury, the brain tissue swells, leading to cerebral edema and increased ICP. Intracranial bleeding may also occur, further contributing to increased ICP. TBI is the leading cause of death and disability in children and adults ages 1 to 44 years. Epilepsy, a brain disorder characterized by recurrent, unprovoked seizures, is caused by inappropriate and excessive nerve impulses within clusters of neurons, leading to uncontrolled and often violent muscle spasms and loss of consciousness. Epilepsy affects approximately 2 million people in the U.S. More than 1/3 of people with epilepsy continue to have seizures despite treatment. Risk factors are more common in children younger than 2 years and adults older than 65. Approximately 10% of Americans will experience a seizure sometime during their lifetime. Alzheimer's disease. Alzheimer's disease is one of many degenerative conditions that affect ICR. It is the most common form of dementia and affects more than 5 million Americans and is the 6th leading cause of death in the U.S. Almost 2/3 of those with AD are women. The most common form occurs in individuals older than 65. The exact cause of AD is unknown, but it is thought to be associated with abnormal plaque formation in the brain tissue and neuron tangles. Meningitis is a pathologic condition affecting ICR. It is caused by inflammation of the meninges. The 5 types are viral, bacterial, fungal, parasitic, and non-infectious. Viral meningitis is by far the most common type and less severe. Bacterial meningitis is less common but is usually severe and associated with higher death rate. The populations at risk, transmission, and treatment vary widely depending on the cause. However, more than 50% of cases occur in infants and children younger than age 5. And this is the end of the slideshow.